Hello everyone, I'm Dr. Kandasamy from National Addictions Management Service Singapore, and I'm going to give you an overview of pros and cons of harm reduction approach for opioid use disorders based on a brief literature review in the next 15 minutes. People with opioid dependence are currently estimated to be around 27 million, and half of them reside in Asia. It is a chronic and relapsing disorder. Clients can cycle in and out of active OUD with multiple exposures to treatment, incarceration, and abstinence over many years. They do present with increased criminal activity with huge economic cost to the society. If left untreated, many users develop mental and physical health problems, carry high risk of infection with HIV and viral hepatitis, and die due to unintentional drug overdose and suicide. Pharmacologically, methadone and buprenorphine are the two common medications given in harm reduction approach. Naltrexone is an opioid antagonist with a focus on achieving total abstinence. Medical heroin is given in countries such as Germany and Switzerland. Non-pharmacologically, inpatient detoxification is a common one, followed by outpatient-based rehab programs. Other methods are prison-based rehabilitation, therapeutic community, and self-support groups. What is the rationale for harm reduction strategy? The harm minimization approach accepts that the drug use will continue to be part of our society. The eradication of drug use is made impossible, and continued attempts at eradication may well result in increasing harm to society. People say it is based on pragmatism and humanistic values, and the main objective is to reduce adverse consequences. It emphasizes measurement of health, social, economic outcomes as opposed to the measurement of drug consumption in terms of achieving abstinence. And it is based on a comprehensive public health framework and built on evidence base. And it has evolved over a period of time from the initiation in the 1980s. And OST remains the most common form of harm reduction treatment, with needle exchange program also is another key part of the strategy. An estimated around 655,000 people are currently registered in Europe alone to receive treatment. And typically they receive treatment for more than 2 years. The main aims are to to establish psychosocial stability by reducing the illicit opioid use, reducing the incidence of injecting and sharing equipment, reducing the use of other street and prescribed drugs in the shorter term, and in the longer term to increase the chance of abstinence from all drug use. What has the harm reduction treatment achieved so far? Well, has been in use for more than 40 years now, and it is used as a substitute instead of heroin mainly because it can stop the craving, withdrawal, and the binge cycle of heroin due to its longer duration of action, and also it won't produce the same highs as heroin. High methadone doses, multiple and longer cumulative treatments are generally associated with more favorable outcomes, and it needs to be given in specialist settings. Buprenorphine is now prescribed as Suboxone, which is a partial agonist-antagonist combination, which seems to be superior to methadone because of its better side effects profile, low risk of overdose and recreational use, and also ease of use. And so it is a good option to use in outpatient and primary care settings. Several randomized controlled trials or RCTs, systematic reviews, meta-analysis, observational and long-term follow-up studies, including few textbooks have been published about OST's efficacy as a treatment during the last 3 decades. Whether it comes to increasing retention in treatment, reducing illicit drugs, use of illicit drugs, reducing risky injecting behaviors and eliminating HIV new infections, or reducing mortality, or increasing life expectancy, or reducing years of life lost due to morbidity, improving physical health outcomes, reducing the social cost of heroin, reducing the criminal activity and imprisonment. OSC has got the best evidence compared to any other treatments according to scientific research at the moment. The most reported benefit was stability and normality with improved capacity to fulfill as a role as a parent, family member, and friends. And in fact, WHO recommends methadone and buprenorphine as first-line treatment for OST, and also it is shown to be very cost-effective. How about pitfalls? Well, generally people do not want to talk readily about pitfalls as opposed to how they want to highlight efficacy in academic meetings according to my own little observations. Well, both legitimate and illegitimate ways of diversion and misuse is very common, and which can pose a huge public health concern. How do they do it? They can remove all part of the dose for self-medication. They can inject excess supply. They can save the dose for later use. They can trade between friends and family for money. And the diversion can also happen through faking opioid dependence and prescription forgery. And this particular type of prescription forgery or doctor hopping can happen in countries with fewer regulations. And drug dealers are another common source. It can be diverted in prisons. And generally, lack of OST programs and suboptimal prescribing practices are reported to be some of the reasons for misuse. Latest European drug reports say that large quantities of buprenorphine and methadone were seized from countries like Sweden, Finland, and Greece in Europe alone in 2017, which indicate that the trafficking and diversion at the retail level is not negligible. And most of the time, the trafficked OST medications originate mainly from the domestic supplies. Now, the demand for specialist treatment related to the misuse of OST medications is actually on the rise worldwide, and it is a big concern in Europe too. Two out of three treatment entrants for primary methadone misuse reported having been in OST before in Europe. 22% of all clients entering specialized drug treatment services in Europe sought treatment for problems with the OST before. Almost all countries report more and more people are seeking treatment for misuse of OST. And in Germany, more people with methadone misuse seek treatment. And in countries like Sweden and Finland, more buprenorphine misuse people are seeking treatment. And also, it is reported that those who seek treatment for buprenorphine are most likely to be injecting buprenorphine. When Suboxone as a combination product was introduced many years ago with the intention to reduce the abuse of buprenorphine, soon after that, Australian studies reported misuse of Suboxone too. So even Suboxone was not found to be 100% safe when it comes to OST treatment. With the misuse, the number of deaths associated with OST have been increasing over the past decade across the world. 2019 European drug report says methadone and to a lesser extent buprenorphine are among the non-heroin opioids which are regularly found in toxicological reports apart from heroin. As you could see from the data that I shared from countries such as Finland, Germany, UK, US, and Norway, all suggest that many of the overdose deaths were related to misuse of methadone and buprenorphine. And most of those people were not in OST treatment at the time of death, which means diversion was the main contributory factor. What are the other pitfalls? Well, the children from those who seek OST treatment have now been reported to have died due to taking overdoses. And individuals who inject buprenorphine are also put at risk of contracting bloodborne viruses again. Misuse increases crime, increases stigma, which further results in poor adherence to treatment. Misuse inside prison causes bullying among inmates. The indirect impact of misuse is decreased quality of life. High attrition rates with 40 to 60% drop out within the first year because the treatment is limited by the need for daily commitment from patients and specialist clinicians. Almost all patients in OST report high rates of relapse despite successfully completing treatment after discontinuation. And this raises the serious question on when to stop OST. And overall, the abstinence rate is about only 30% at 10 years follow-up with OST treatment. And extended OST causes clients to lack aspirations to quit according to studies. And many of them actually continue to use alcohol and other drugs despite successfully stopping opioids. Let's look at the efficacy of non-OST treatments. Well, to summarize, it is not great either. 91% relapse after detoxification and 60% relapse after 1 week and 70 to 90% relapse after 36 months. You know why? Neurobiologically, the neural adaptation that can occur in response to chronic heroin exposure, they are not immediately reversible after detox. Residential supervised withdrawal still associated with poor treatment outcome in the medium to longer term. Forced periods of abstinence such as incarceration are often followed by relapse with increased risk of both fatal and non-fatal overdoses soon after release, mainly because of loss of tolerance to opioids. And therapies like CBT, coping skills training, MI, self-help groups, peer support, all these interventions are endorsed by various national agencies, but the availability of evidence supporting the efficacy varies widely. And these approaches Generally, they do not have the extent of the robust evidence that one could commonly see with OST, and they are mostly considered for the potential synergistic benefit. Oral naltrexone still high dropout rate despite pharmacologically being an effective treatment. To summarize, despite being well delivered and having sound evidence base in overall reduction in harms and achieving stability in short to medium term, the negative impact of misuse and diversion of OST medications, including a broad range of negative outcomes for the individual and for the society, they are not just small problems to solve, they are indeed very significant. There is a consensus that harmonization approaches may be neglecting to focus on a range of outcome domains that are required to improve the quality of life for heroin patients in the longer term. There is also a lack of documented evidence of the quantitative impact of misuse and diversion, especially with regards to quality of life of those misusing OST medications. Also, there are no clear definitions in the existing strategies in quantitative terms to support a significant change in treatment delivery and care by addressing misuse and diversion. To add on, the uncertainties in assessing and responding to diversion and misuse may be a key factor deterring physician participation and even some countries' participation in OST program. Diversion has threatened the reputation of treatment services and has compromised public acceptance of OST. Certainly, further research is needed to better understand the drivers and to define strategies that can effectively reduce misuse and diversion. Experts also note that prescribing more abuse deterrent forms of medications could serve as one intervention among others within the OST system to potentially increase quality, acceptance, and access to treatment. And certainly recent advances in pharmacological treatment options, which includes depot and implant formulations which can offer a longer duration of medications and thereby can reduce the risk of abuse and their impact on the longer term course of opiate addiction remains to be seen. To conclude, it is a big challenge to treat opioid use disorder clients, considering the chronicity, variations in vulnerability and risk profiles, long-lasting brain changes, comorbid issues, and various social and legal problems that they face. Despite having good evidence in reducing harms, without addressing the problems associated with diversion, one cannot be very confident of its all-round success. There is also a lack of robust evidence from non-OST based psychosocial interventions as well. Other big challenge is how do you bring together all the relevant parties to address OUD at a public health level, as political and professional attitudes to scientifically established OST are highly variable between countries and even within countries. Also, little clarity on the concept of recovery. Wider definitions of recovery support the concept as a process rather than an endpoint like achieving abstinence. So, despite highly evidence-based treatments are available for more than 40 years, there is still uncertainties exist with regards to what is the best approach to treat OUD patient. So more research is needed as to how we can combine these two approaches together, the harmonization and abstinence base, to achieve more meaningful outcomes for our patients. Finally, should we consider harmonization approach in Singapore? Well, to answer this, perhaps we should look at collecting independent data first on the actual prevalence of OUD with its complexity at the population level. We should also look at data from all the agencies, including efficacy data from prison and community agencies, the recidivism rates, data from NAMS on the effectiveness of its detoxification and relapse prevention programs. When we sit together and analyze the above data holistically, it will give us an idea on how big or small is the heroin addiction related public health problem in our country in comparison with much bigger countries. It will give us an idea on whether the existing abstinence-based programs are sufficient or not. It will also give us an idea on the gaps in our existing treatment models in achieving meaningful recovery and whether that can be addressed by other evidence-based approaches such as OST. And so more honest debate and discussions are needed. And I would say we should consider embarking soon on a major academic exercise between all the relevant stakeholders to answer this question. Meanwhile, I would strongly emphasize that we should establish much wider and seamless coordination between all the stakeholders to improve the effectiveness of our existing abstinence-based programs in our country. And the citations of the articles that I looked at for my presentation or in the next slide. Thanks for listening.